Hello, everyone. Thank you so much for being to today's webinar. My name is Veroniki, as Areti said. I'm a co-convenor of the Statistical Methods Group, and today we're going to discuss about analyzing other outcomes and study designs. I would like to acknowledge and thank very much Miranda Compston, who put together the slides based on material by Julian Higgins, Ramsey, Cochrane Statistical Methods Group, and others. So we'll use this material today. And as you already discussed in the previous sessions, the major steps in a Cochrane review are usually those 10 steps. Today, we are going to focus again on step number 8, on the analysis and presentation of the results, and particularly on the different study designs that you may have in your review. So the purpose of this presentation is to introduce some of the non-standard types of data and designs, study designs. In the previous sessions, you talked about meta-analysis of the most common data types, such as dichotomous and continuous data. But then the next question is, what if your data doesn't look like that? How can we meta-analyze these different types of data? So the first thing we're going to do is to talk about the generic inverse variance method of meta-analysis. And then the remaining session outline is to discuss about other outcome types, multi-arm studies, cluster randomized trials, crossover trials, and non-randomized studies. So all this material and more details can be found in the Cochrane Handbook, chapters 6, 10, 23, and 24. And I would strongly encourage you to read these chapters to familiarize yourselves with these types of outcome data and study designs. Now, in many studies, we don't have data summarizing the results for the separate intervention groups, such as the number of events for each group, as we had in dichotomous outcome data, or the means and standard deviations for continuous outcomes. So many studies may also report just an effect estimate, risk ratio or odds ratio or a mean difference. We may also have adjusted odds ratios coming from a regression analysis, in which case, of course, we need to record the factors that have been adjusted for. Or it might be adjusted for a study design, different study design purposes like the cluster or crossover trials that we're going to discuss in the next slides today. Or we may have non-randomized studies. So the good news for this is that we can use a certain method to meta-analyze any of these statistics. So this method is the generic inverse variance method, and it can be used for any effect estimate, and it's a common meta-analysis method. So generic means that we can use it for any statistic, and inverse variance means that the inverse of the variance is used to weigh the statistics in the meta-analysis, similar to what we do for dichotomous and continuous outcomes. So the weight given to each study is chosen to be the inverse of the variance of the effect estimate, so the 1 over the squared standard error, and that's under the fixed effect model. And in this case, larger studies which have smaller standard errors are given more weight compared to the smaller studies which have larger standard errors. So this approach, this choice of weights, minimizes the imprecision of the pooled effect estimate. So the only data that we require for this method are the estimate of the treatment effect and the standard error. Now, if other studies report raw data, then we can calculate the effect estimate and the standard error for them using Redmond, for example, calculator, and then we can combine them all the studies using the generic inverse variance method. Now, to use this method in Revman, first we should indicate the statistic that we are going to use, such as the odds ratio, the hazard ratio, and so on. And then we need at least 2 studies that report this effect estimate, or at least to be able to calculate this for each study. For example, if we have several studies reporting raw data for weight gain as a continuous outcome, and some other studies report the mean difference without the group data, then we can use Revman to calculate those mean differences, and then we can combine all the studies using the generic inverse variance method. Or in other cases, we may have the 2x2 table in some studies, and the odds ratios, for example, reported in other studies. So again, you can calculate the odds ratio in all the studies, and then using the log odds ratios and the standard errors, we can combine them all using the generic inverse variance. Now, so for each study, you'll need to enter the selected study statistic and the standard error. But here I would like to highlight that for continuous data, we do not use the standard deviation in this case. And also in continuous data, we don't need to include the sample size, given that this information is already incorporated into the standard error. So what we need to use is only the two specific numbers that we said, the effect size and the standard error. Now, if we don't have the standard error, but we have some other data, such as the standard deviation and sample size, or we have confidence intervals and p-values, again, we can calculate the standard errors in Revman using the calculator. Now, for more information, if you're more interested in the formulas, we can find all these formulas in the Cochrane handbook, and we can also in chapter 6, and we can also use, for example, those formulas in an Excel file if we want to calculate those outside Revman. Now, in Revman, you'll need to add a new outcome and select the generic inverse variance outcome data type. And then you'll be able to choose which statistic, which effect size you're going to use from this drop-down menu. And then Revman will calculate a data table for you. You can see that in this case, we only have room to enter two numbers for its study. So we have the statistic, and here it's the log hazard ratio, along with the standard error. And on the forest plot, as we can see, the key difference here is that the squares, which represent the effect estimate for its study, they are depicted in red color, and that shows us that we have used the generic inverse variance approach. Now, an important note here is that if your statistic is a ratio, whether we have an odds ratio, a risk ratio, a hazard ratio, then as you probably know, the ratios are not normally distributed, which is a prerequisite for our meta-analysis, but also a negative effect ranges from 0 to 1, and a positive effect ranges from 1 up to very large numbers, up to infinity, let's say. And because of these reasons, ratios are usually log transformed before they entered into the meta-analysis. And because a generic inverse variance outcome type in Revman can use either ratios or absolute measures, we need to tell Revman which of those we are using and ensure that the analysis is correct by log transforming those ratios before we meta-analyze them. Now, when the analysis is complete, Revman will automatically convert the results back to the original scale, back to the odds ratio, for example, if the odds ratio is the scale that we chose, and these will be displayed in the forest plots. So more details can be found in chapter 10 of the Cochrane handbook. Now, how can we tell Revman about this? If you selected one of the default ratio measures, the risk ratio, as we said, the odds ratio, Revman can automatically be informed that you will be entering the log transform data. And therefore, you will need to check the option that says enter data are on the log scale. And this way, we're going to tell Revman that we are entering the data on the log scale. You can also use this window to ask Revman to add columns for the number of participants in its group to the data table. But of course, this is not required for the analysis, but it's good practice to present this data, this information to our readers. Then you need to transform the data for Revman. So Revman calculator, as we said, can be used, and we can do those calculations. For example, here we can enter the hazard ratio and the 95% confidence interval in the calculator, and then Revman will calculate the log transform values, which we can once we click this button, update the data table, then we can obtain the log hazard ratio and standard error to enter those values into the analysis. Now, let's move on to the next topic of this presentation and talk about other outcome types that you might come across in your review. As you already know, dichotomous and continuous data are the most common data types that are being used in meta-analysis, but there are another 3 other common types of data that you may also find in your review, and these are ordinal data, counts and rates, and time to event data. Now, let's start with the ordinal outcomes. So ordinal outcomes are scales with some sense of order or magnitude. They can be numerical scales, such as scores out of 5, or even long measurement scales, such as quality of life or function tools. And they can also include, for example, conceptual scales, such as those measuring strength of agreement or satisfaction. So there are several options available to analyze this ordinal data, but the choice depends on the data that are reported usually in the included studies. So when we have short scales, these can be turned into dichotomous data, for example, by dividing the scale into 2 groups. Let's say that we have 4-point scale of pain, where 1 corresponds to no pain and 4 corresponds to severe pain. Then, in that case, we can divide the data, for example, into those with no pain, with a score of 1, compared to those with any pain with scores 2, 3, or 4. Or an alternative way would be to divide the group into those with mild pain with scores 1 or 2 versus those with strong pain with scores 3 or 4. You may come across studies that treat the short scales like this, or if you have enough information, that's something that you can also do yourselves to dichotomize the scale by yourselves. But while we are doing this, it is important to choose the cutoff point without reference to the results. And when we choose this cutoff point, we need to provide a rationale for this selection. In any case, we need to be careful with this process. We shouldn't be adding any biases in this process. For example, we shouldn't be trying to maximize the difference between the 2 groups. Then we may have longer scales. The longer scales usually behave like continuous measures. Long ordinal scales are often treated also in the publications as continuous data. They report the mean scores and standard deviations for its group. But of course, these are not continuous data in the way that we have it in mind, because they don't really report values anywhere on the scale. We can't always have half scores or decimal places. So sometimes also the scales may measure qualitative rather than quantitative differences. So things like that should be considered. Now, advanced analytic methods are available to analyze ordinal outcome data, such as using the proportional odds ratios, comparing its category and the scale to each other. And then proportional odds ratios, we should know that they can be analyzed in Revman using the generic inverse variance method. Now, if we choose that process, then in this case, again, similar to what we have been doing for dichotomous data, we need the log odds ratios and the standard errors from the proportional odds model. Now, although it's preferable to pre-specify how you plan to analyze the ordinal data in the protocol, this depends really on the reporting data from the studies that we include in the systematic review. So reporting may vary across the studies. We may have one study, for example, reporting data separately for its individual category, or we may have studies that dichotomize the scale, and perhaps at a different point of interest that we would like to include. So what we suggest is that at the data collection stage, It is important to collect the data in as much detail as possible so that when it comes to conduct the analysis, then we'll have all the options that we can, as many options as possible so that we analyze those data. And of course, if we decide to dichotomize the scale by ourselves, then it would be nice to conduct a sensitivity analysis to test the impact of the choice of this cutoff point. Next, we may have counts and rates. Counts and rates describe the frequency of events in a certain period of time. Sometimes of event can happen to a person more than once. So we may have, for example, hospitalizations. We may have falls. We may have adverse reactions. So these are the types of counts and rates. So it may be preferable or necessary to address the number of times that these events occur, rather than simply saying that whether the person experienced an event or did not experience the event, so that treating them as dichotomous data. And that's because it is important to account, whatever we can, the number of times that this event happened to its participant. So we have the rates, and the rates here can incorporate the aspect of time. So it accounts how many events occurred during a particular period of time, during a day, during a year, or a person year, depending on what the study reports. And again, there are many ways in which the counts and rates can be analyzed. Now, a common mistake is to analyze the counts and rates as simple dichotomous data using the number of events and the number of participants or person years of follow-up, and then analyze them like this. I'll give you an example here, using, for example, the decayed teeth. So we may have the number of decayed teeth, which were filled during a trial. So we may count these decayed teeth as events, but this is not the same information as the number of people who had a filling. So it would be possible to have decayed teeth more than the number of participants that we would have in the trial. So then that wouldn't make sense to analyze those as a dichotomous outcome. But it is possible to analyze this data as dichotomous only if we determine the number of participants in each group, where we say that the number of participants, we are interested in the number of participants who experienced at least one event. So that's a different question. Or it would be possible to analyze counts of frequent events as continuous data. We could potentially use the mean number of events occurring for each person, and then we would also have a standard deviation. However, analyzing the data like this, it would be potentially give us skewed results, so we would need to consider for that as well. Or another approach would be to analyze this kind of data as the time to having a first event. So we will be discussing this, the time to event data, in the next slide. However, when it's possible to extract the number of events in its group and the person time at risk for its group, then we can analyze the count data as rates. So the effect size usually in this case is the rate ratio. So the rate ratio is the ratio of the rates in the intervention group and the rate of the control group. So we have the number of events divided by the amount of time over which they occurred in the intervention group, and the same for the control group. But again, detailed data on events and person years are not always available in the studies. They might actually present an estimate of a rate ratio or a rate difference. So these can be used instead for our meta-analysis, and we could use this along with a 95% confidence interval or a standard error, using again the genetic inverse variance method. Again, although it's preferable to pre-specify how we're going to analyze the data in our protocol, the choice may be determined by the way the data are reported in the included studies. And we need, again, to collect as many details as possible during the data extraction stage so that we have more options in the analysis. And then we have the time to event or survival data. And these are relevant when the interest is focused on the time elapsing before an event is experienced. So time to event data measure the time each person takes before a certain event occurs. So, for example, we may have cancer, we may have deaths, we may have hospital admissions. And in this type of data, we have pairs of observations per individual. So we have first the length of time during which no event was observed, and then we have an indicator of whether the end of the period corresponds to an event or just the end of the observation. Now, it is possible to analyze time to event data as the hypothesis outcome data if information is available on how many people did or did not have an event for a specific time point, but we need the information of all the participants for the specific time point. However, it would not be appropriate to analyze this data as continuous outcomes, using the mean length, for example, of time before an event occurs. And that's because the data in these trials are censored. And that means that we only measure data until the end of the study. Now, if some people don't experience the event before the end of the study, that means that we don't know the actual length of time they took before the event occurred for them. So we would have to exclude the study from the analysis, and that would actually introduce bias. A more appropriate analysis for time to event data is to use the hazard ratios. So hazard is a similar idea to risks, but hazards measure the risk at specific times. And this risk will change over time. So, for example, we may measure the risk of an event, such as death, as we said earlier. And this risk changes as we age. Or it may change as we engage in dangerous, let's say, activities like crossing a road or, highways would be, I guess, very dangerous. So now we have the hazard ratios. A hazard ratio describes how many times more or less likely a participant is to experience the event at a particular point in time when they receive the experimental intervention compared to the control, let's say, or the comparator intervention. And an optimal approach for meta-analysis of time to event data would be to obtain individual patient data from the original studies, reanalyze those data, obtain the hazard ratios, the uncertainties, the standard errors, and then perform the meta-analysis. This approach is not always to obtain individual patient data, and this is why we concentrate most of the times in the aggregated data and what the studies report in those publications. So we usually obtain the hazard ratios and standard errors. Those hazard ratios may come from Cox proportional hazards model or any other regression models for survival data. And then we use the log hazard ratios and standard errors across the studies, and then we analyze those in a generic inverse variance method. Now, another approach would be to estimate the hazard ratio approximately using a log rank analysis. So we can obtain or we can estimate the log hazard ratio using the observed number of events in the experimental intervention and the expected number of events in the experimental intervention. So the log rank statistic and the variance V can be actually entered into Revman in that type of data, and then use the generic inverse variance. But overall analysis of the time to event data, I'll say that it's a bit challenging. We have different ways that these results are reported in the studies. Okay, so next we'll talk about studies with more than one intervention group. There are several options available to analyze the studies, which have more than one intervention groups. We may have 3 arms, we may have 4 arms in a study. So what we need to do is first to check to make sure that each of the intervention arms is relevant to the question of interest. Say, for example, that you're interested in the effect of chemotherapy versus radiotherapy. And you find a study that also includes a 3rd arm receiving, let's say, surgery. So it is we need at this point to determine whether the effect of surgery is also of interest in the specific review that we are conducting. If it is not relevant, then we can just ignore the specific arm and analyze the other 2 arms. But in the case that all arms are of interest, then you will need to consider how best to include them in your analysis. And that's because Revman requires pairwise comparisons. So if we would like to include everything, then we would have 3 comparisons. We would have chemotherapy versus radiotherapy, surgery versus radiotherapy, and surgery versus chemotherapy. Otherwise, we can consider which or whether 2 of the arms that we have from that study are clinically relevant or clinically similar, actually, to combine those results together and treat them as one group. For example, you may have a study that's a 3-arm trial that compares a high dose of a specific drug, a low dose of the same specific drug versus placebo. Or you may have 2 drugs that belong to the same class, and these compared to placebo. So in this case, we may consider that it is clinically reasonable to combine those 2 arms, the high and low dose, for example, groups, into one, especially when we have other studies in the meta-analysis that actually have done the same thing, and they don't present the results according to the different doses. But of course, we can always explore the effect of those differences in a subgroup analysis. Another option that you would have is to conduct more advanced analysis, comparing all groups that have been used in a trial using a network meta-analysis. However, this is not available in Revman, and you would need more statistical expertise on this. An important point to make about analyzing multi-arm studies is the importance of not double counting people in a meta-analysis. This can lead to what we call a unit of analysis error. It refers to the collection of problems that can happen when we make choices around the selection of the number of participants to include in the meta-analysis of the studies. So some studies, according to the choices that we're going to make, some studies may get too much or too little weight, and we always need to be careful to give the appropriate weight to the individuals and the trials into the studies. So if we double count, let's say, if we include the same study twice in the forest plot, that means that we are going to double count the people and give double the relevant weight in the meta-analysis, and that would be incorrect and impact our summary effect. Now, in this example, we have a 4-arm trial, the Oracle trial here. It looks at antibiotics for inhibiting preterm labor. We have antibiotic A versus antibiotic B versus a combination of those drugs versus no intervention. So in this review, the authors were asking a broad question about the effects of any antibiotic versus no intervention. And the other studies included in the review looked at the range several antibiotics. So the authors decided that it made clinical sense to combine all those 3 antibiotic arms in a single arm compared to no intervention. But here is an example of one way that we can combine the 3 arms on a forest plot. So as you can see, we have 3 groups from the Oracle trial. It is compared to the placebo group, and we have included those in the forest plot. The problem here is that by including the groups this way, the authors would be counting the control group 3 times in this forest plot. So we would be giving those individuals 3 times the relevant weight in the meta-analysis. And the specific study, as you can see, takes about 70% of the total weight in the meta-analysis. And here is the summary effect at 0.92. Now, a more appropriate approach would be to split the control group between the 3 intervention arms, making sure that each person in the control group is counted only once. And by doing this, we can see that the weight now for each of these arms has dropped considerably, and the weight actually for the specific study has dropped to the 50%. And also we can see that the risk ratio, the pooled risk ratio, has changed from 0.92 to 0.88. Now, another approach, and the one that actually the authors actually took, is to combine those antibiotics into a single group. And this was more relevant for the authors because they were including studies that ranged different antibiotic types. They didn't focus on a specific one. An alternative way to analyze the groups would be to include them on separate forest plots. In this case, we can see that there are 2 categories of antibiotics in this review. We have the beta-lactam antibiotics and macrolide antibiotics, and then some studies that look at their combination. And each antibiotic arm of this Oracle trial falls into each of these categories, along with several of the other studies in the review. Now, because there is no overall meta-analysis combining those groups, it is okay to include the whole group, the whole control group in each of those cases. So when we are faced with, we come across a trial that has at least 3 intervention groups. So what we need to determine is which intervention groups are relevant to the systematic review, which intervention groups are relevant to the particular meta-analysis that we are conducting, and how the trial will be included into the meta-analysis when we have multiple groups relevant. Now, let's take a look at the cluster randomized trials. This is a study design that you may encounter into your review. So in a cluster randomized trial, instead of allocating individuals to the intervention or control group in a study, we have whole groups of people, we have clusters that are allocated together, such as schools, we may have hospitals, we may have families, and everyone in the cluster receives the same intervention. Now, the benefit of this approach is that contamination of randomized individuals is avoided. So these trials can be used to examine, let's say, interventions that are targeted at whole clusters like towns, as we said earlier, like villages. We may be interested in herd immunity of a vaccine, for example. Now, in a simple randomized clinical trial design, the unit of randomization and the unit of analysis are the individuals. In a cluster randomized trial, we have groups of individuals rather than individuals, as we said, and these are randomized to the different interventions. So the unit of randomization here is the cluster. And one of the main properties of the cluster design is that participants within a cluster, they often tend to respond in a similar manner. They share common characteristics. So we can really consider anymore that they are independent. So we need to take into account this correlation and avoid treating the participants as if they were individually randomized. And to analyze cluster randomized trials, we could, for example, either consider to use the clusters as a unit of analysis. So we would conduct the analysis at the same level as the allocation. So the sample size of our analysis would be the number of clusters. And this would be appropriate if our study was looking for effects at the cluster level. However, we lose information at the individual participant level using this approach. And precision of the effect estimate will be reduced, given that clusters vary considerably, usually in their size. So the ideal information here is to extract the estimate from an analysis that has properly accounted for the cluster design. Usually those studies report effect sizes from multi-level models or generalized estimating equations models. Or another approach, another option would be to use individuals as our unit of analysis, similar to considering a randomized control trial where the unit of allocation is the participants. But this is incorrect. We will run into a unit of analysis error here because the unit of analysis is different from the unit of allocation. Now, if the clustering is ignored in a cluster randomized trial and analyzing the results as if individuals had been randomized instead of the clusters, then we will result in confidence intervals that are very narrow, short. The p-values in that sense will be very small, will be artificially small, and that will lead to false positive conclusions that the intervention, for example, has an effect. So, and that would be because we are ignoring the clustering in these cases. So we wouldn't have the appropriate weight in the meta-analysis for the specific studies. And a similar approach, a similar case actually would be if we considered body parts, if we considered teeth, if we considered eyes. So these observations are clustered within individuals. So the analysis now takes place by the individual units, the tooth, the eye. So we need to account for the clustering, that these belong to participants, to individuals, so that we do not get a unit of analysis error. Now, the difficulty, as you understand, in cluster randomized trial is precision. When we are interested in outcomes at the cluster level, we can analyze by clusters, and that's fine, there's no problem. But we need to be careful when we are interested in the effect at the level of the individual. So whether we analyze the result by the number of clusters or by the number of individuals, our estimate, the intervention effect will be the same. What it's going to differ is the confidence interval, is the precision. And as we said, this is important in our meta-analysis because we use the variance to weigh the studies. So if we get the precision wrong, then we give too much or too little weight in the meta-analysis, and this will impact the summary result. Let's consider an example where we have 10 schools. We have clusters, the 10 schools, and each school contains 300 students. If we use clusters now as our unit of analysis, then the sample size in our analysis would be 10. In a meta-analysis, a study with 10 participants will have very wide confidence intervals. They will be assigned a very small weight into the meta-analysis event. So that would be incorrect, this approach, if we would be interested in the effect of the individuals. And in fact, as you can tell, we have a lot of information. We have a lot of people. We have 300 students per school. So we don't really account for this sample size in this way. The other option would be to take the number of students as the sample size. So here we would have in total 300 students. So the study would get narrower now, confidence intervals. We would give a lot of weight in the meta-analysis. But the problem here is that this way we haven't accounted for the correlation. So that should be taken into consideration. So the students in a particular school or the patients in a particular clinic are likely to have a number of common characteristics, as we said in the beginning. They might, they live, for example, in the same city. They share the same socioeconomic status or similar. They have similar patterns of health and so on. So individuals within a cluster are likely to be more similar compared to if we had a random selection of those individuals. So we have a level of correlation that should be taken into consideration. Now, if the individuals within the clusters are very correlated, then by adding more people into the studies, we don't really get as much information as we would like to have, because the results calculated would be more or less at the cluster level, would be closer to that side. But if the clusters have minimal correlation, adding more individuals to the study, that would actually give us more information for the effect. Also, examples of the cluster randomized trials may be when individuals are randomized, but we still have clusters where, for example, the intervention is delivered by a number of practitioners. These practitioners would actually create clusters of patients who receive the intervention from its practitioner. Or we may have another example where we have joint replacements on both knees or fillings in teeth. Or we would have several cycles of treatment, such as fertility trials and so on. Now, how do we take this clustering into account into the analysis? You may actually find a number of approaches in your included studies. You may come across studies that have used advanced methods. As we said earlier, we may have multi-level models, generalized estimating equation models. And in this case, if your studies are reporting this effect size, adjusted addresses, for example, accounting for this correlation, we can use those into our genetic inverse variance meta-analysis. Alternatively, you may find studies that do not correctly adjust for correlation, and in these cases, we would need to obtain as much information as possible. The correlation in these cases is called intra-cluster correlation coefficient. So if we have this information, then we would be able ourselves to calculate, to adjust for this and calculate the effective sample size, for example. More details about these calculations can be found in chapter 23 of the handbook. But whatever you do, you need to explain how you managed, how you dealt with this data in your review. So we have here an example from a Cochrane review of education of children and adolescents to prevent dog bite injuries. The authors have shown the impact of a range of assumptions about this intracluster correlation coefficient, the ICC. Here, for example, we see when the ICC is equal to 0. We can see when they accounted for an ICC equal to 0.59, 0.01, and 0.2. And you can see that the numbers here, the effective sample sizes, chains and events. So you can see that this has an impact in the precision and the confidence intervals while accounting or not accounting or accounting different levels of these correlations. And of course, this would have an impact at the summary effect, depending on the precision that we get from its study. That's another example where we have those two studies here by Adam and by Smith. Here we have no adjustment in this standard error, but then we can see that the standard error actually changes, becomes larger compared to before. And then this is actually will be affecting the confidence interval, of course, and the pooled effect in the end of the summary effect. Now, another study design that you may come across is the crossover trials. So we have parallel group trials that allocate its participant to a single intervention for comparison with a control group or other interventions. Now we have crossover trials, which trials allocate its participant to a sequence of interventions. We may have participants allocated initially to intervention A or B, and then they cross over to the other intervention B or A, respectively. So in a crossover trial, everyone receives both experimental and control interventions. In a randomized control trial, this order of which the interventions are received is random. So we may have in the first period people who got intervention A and intervention B, and then they switch to the other for the second period. Now, the advantages of the crossover trials are that each participant acts as their own control. We need fewer patients with participants to obtain the same precision in the estimation of the intervention effects. And every participant receives every intervention in this trial. So we can also see any preferences in the interventions. So rather than having two separate groups and comparing results between the people in those groups, we are measuring and comparing the results within each individual. First for intervention A and then the alternative intervention B. The first period, if we note in the first period of the crossover design, that actually is the same as in a parallel group trial. So what we need to consider is the second period where we actually have this crossover. You may also encounter designs more complicated than this that we see here. We may have multiple interventions. We may have more than two periods, but this is the general idea of the crossover trial. Now, crossover designs are not appropriate for every study. In order for the results in the first period and second period to be comparable, we need to assume that nothing has affected the participants' responses over time. So we need to assume that the condition the participants have is stable over time and it doesn't deteriorate or fluctuate. Okay, so we don't want the first intervention to be having an effect when we try to measure actually the effect of the second intervention in the second period. So crossover trials are suitable for evaluating interventions with a temporary effect, with stable conditions, but they are not suitable for intervention that causes actually that cause permanent changes, death, for example, or even complete cure. That would not be appropriate. Or if we had a long-lasting effect of an outcome, let's say, such as infertility treatments when we have pregnancy. So the key problem in crossover trials is the carryover effect. And the carryover is a situation in which the effects of an intervention that was given persist into the next period. So we need a sufficient washout period after the first intervention to assume that the patient is back to the baseline condition so that we are able to assess the second period. But if there are none of those problems, there's no carryover effect, then we can actually take advantage of this within person comparison. Now, overall, the sequential measurements taken in individuals are correlated compared to using separate groups of individuals. So if we don't take this correlation into account, the smaller sample sizes will get too little weight in the meta-analysis. And as we said, when we conduct a meta-analysis, we need to give appropriate weights to individuals and trials. If we're not careful, then we will be adding this unit of analysis error. also, the type of analysis issue will be encountered in individual randomized studies where we have the clusters are the people, where we have treatments for knees, for example, or for body parts, for teeth, which are actually forming a kind of cluster. Randomizing its body part within an individual separately, like, for example, having one knee receiving treatment A and the other knee receiving treatment B, then we need to account for this correlation because they belong to the same individual. And we can consider also for this kind of crossover trial. Now, as in previous cases, the approach that you take may be limited by the level of detail reported in the study. Some studies may appropriately take the correlation into account using a paired analysis, measuring the difference for each participant between the intervention and the control, and summarizing this as a mean difference, for example. In that case, we can take the results the way they are reported, and we may have a group of studies reporting the data this way, and then we can use the generic inverse variance method to meta-analyze them. But if the study does not take correlation into account, for example, if they just give you the mean result for all participants in the intervention and the mean result in the control group, then you may be able to adjust the data yourself. And if you have additional comparable data, you can combine those studies with other studies in your meta-analysis, again, using the generic inverse variance. There are more details in chapter 23 of the Cochrane handbook, and you can also take a look. I strongly encourage you to take a look when you encounter such issues, such types of data and studies in your review. Now, here's an example of a forest plot containing some crossover trials. We have study Johnson here. We have the Kua, Nocida, and Jenkinson, and some other studies that have been combined together in a review of opioids. And this forest plot here treats all the studies as parallel. We haven't considered any correlation here. But then, so correlation in the previous case was 0. But then accounting for the correlation, adjusting for the study design, we can see that the confidence intervals now become a lot narrower. And that means that they get also more weight in the meta-analysis. So although here we can see that the overall effect estimate didn't change much, it gets actually preciser after the adjustment. So it is important to account for this correlation in our meta-analysis. And finally, we should mention that some reviews will also incorporate non-randomized studies. Non-randomized studies may include control before and after studies, interrupted time series. RCTs may not be practical in these cases. We may have cohort studies and other types of observational study designs. If you plan to include these designs in your review, please be aware that different methods for the analysis of those results apply here. So we need to consult the Cochrane Handbook, chapter 24, to get more advice in these aspects. Now, what should we include in our protocol? So, of course, we can't predict every possible case. But what we try to always report in our protocol is to describe how we're going to handle any of these expected situations, including the statistical measures, the outcome types, the study designs. So how you plan to deal with all these difficult situations and the different reporting from the individual studies. And finally, as a take-home message, we need to consider that there are special methods needed to address some of those outcome types and study designs. Of course, we need to be aware of those issues. I strongly encourage you to take a look at the Cochrane Handbook for all these details. We can always keep in mind that we can use a generic inverse variance method to meta-analyze these summary statistics, and meta-analyze the study design, the study treatment effects. But we need to always be careful to give appropriate weight to the included studies, to not run into unit of analysis errors. And whatever assumptions we make, even if we plan to make some approximate analysis or sensible assumptions, as long as you discuss them with your team, please report those assumptions. And you may also want to consider conducting sensitivity analysis to examine the robustness of the meta-analysis into the chosen assumptions. Here are some references. And again, I would like to acknowledge Miranda Compton for these amazing slides. I will stop here and I will stop sharing. Okay, so yeah, I'm happy to answer any questions as they come up.
Thank you, RJ. That was a very useful presentation. So we have a question in the chat. Sometimes observational studies are nested in RCTs. Is there any information how to handle data of observational studies in such cases?
So we have observational studies nested in RCTs. If there's information how to handle data. Yeah, that's a great point. I don't think I have a specific answer to this, to be honest. Potentially we would need to deal or consider the specific observational studies separately, as separate studies from the RCT, right? So if that would be the part of the study that would be relevant to our review, I guess we would focus only on the observational study. And we would deal with this in a similar way, I believe, to what we would be doing in any observational study, despite the fact that they are nested in RCTs. Oh.
Yeah, Priyanka asks if she can unmute and ask the question. I'm not sure about that, Dario. Okay, so I guess
Hi,
we can. Yeah, we can hear you.
Yeah. Hi, thank you for the presentation. So my question actually meant that in RCT sometimes the observational studies are nested, but they are ideally not observational studies because the groups were already randomized. So the population is not exactly in an uncontrolled setting. So if we would compare the data of such an observational study with other observational studies which are not nested in RCTs, would it be incorrect?
Yeah, that's a very specific case, to be honest. Thank you, Priyanka, for this question. Again, I would be inclined to consider these as observational studies, given the nature of that part, right? So I would potentially consider this as an observational study and then follow the specific steps as we discussed, and then potentially conduct a sensitivity analysis to see how results change. Maybe, I don't know if I have any other suggestions to this.
No, I don't think I would. To my mind comes the follow-up studies, to be honest, the follow-up studies from RCTs. That's what I had in mind. But yeah, we usually handle them as non-randomized studies, this one. So yeah.
Yeah, thank you, Priyanka. That was a great question.
Thank you.
Okay, so we have another one. So what key methodological issues should be addressed when conducting a meta-analysis of the dichotomous outcomes that include studies with different sublink designs? specifically some using cluster sampling and others with non-probability samplings?
Yeah, so I think that in a meta-analysis of dichotomous data, and considering that we have different study designs across the studies, including the meta-analysis, we would consider all these aspects for the cluster RCTs that we discussed today, for example, and then I would suggest we perform a sensitivity analysis to see if the what is the impact on the summary effect. So I don't understand entirely potentially the question, but please let me know if I address this. So overall, I want to say that we would follow the same practices. We would perform the meta-analysis using the different study designs. We have cluster RCTs, we have RCTs, for example. If you also have non-randomized, you have non-observational studies. Okay, so then I think we would be able to combine them in a single meta-analysis, right? And then perform a sensitivity analysis to assess the robustness of the results.
Okay, thank you, Archie. And we have another question for Priyanka. Would unit of analysis issues and missing data issues arise if meta-analysis is not possible due to heterogeneity?
Right, that's another great question. So if meta-analysis is not possible, then due to heterogeneity, then I would certainly suggest if it actually is clinically reasonable as well, to not meta-analyze the data if you have such high heterogeneity. And also there is another webinar, the next webinar that actually we'll be discussing about how to present those results when we do not conduct a meta-analysis. But then the unit of analysis issues run when we're making wrong decisions about the sample sizes, as we said, to be included in the meta-analysis, the number of events, and if we consider the wrong data, let's say, if we do not account for the correlation, so these would actually add the unit of analysis errors in our meta-analysis.